Please help spread the message of frequency-specific microcurrent by clicking on the like button. You can subscribe to us on YouTube or any podcast app. If you have any questions, please leave them in the comments. You can find the podcast transcription at frequencyspecific.com, as well as more information about frequency-specific microcurrent.
Big questions right off the bat. I have a really interesting, it's a good one that, you know how people email you questions, people have come to the course. And so somebody who was just at the Arizona course, took my course, took your course, stayed for the advanced, I believe. Really good person, really bright PT. So I have her question. I said, you know what, I'm going to not reply to this on email. I'm going to talk about it on the podcast. So I want to on too. I think we have lots to talk about today.
And we'll send her the transcript and let her read the reply in case she doesn't hear us.
Yes. How is your week? How are things?
Oh,
That could be a good or like a
oh no, it was yesterday and the day before were amazing. A patient that had an accident that basically took off the front of his face with a shotgun.
oh.
And so he was on a trach for 3 years while they did 200 surgeries to try and create a nose. They took a piece of his skull and made a little nose and brought in this skin because this whole part of his face was missing. Brought in the skin. And the first day, the thing that bothered him the most was on the right side, there was a bunch of scar tissue. And it's scarring in the connective tissue, scarring in the nerve, scarring in the artery. Worked on that. And that all softened up. The next day he came in and said, it's very strange. Now I have pain that I didn't have before that goes up here. I got up volume 1 of Travell and Simons. And the trigger point pattern for the facial muscles, the orbicularis oris, and this one, whose name I can't remember, and the platysma. Number one, he had no ability to contract his platysma. I didn't notice that he didn't have an ability to contract it until he contracted it. And you look at him and go, your face is moving different. And then yesterday, I wanted to work on the other facial muscles. And I just put a washcloth on his forehead. And there's the place where they took a piece of his skull out to make a little nose, very tiny nose, and a very small mouth. And so I put a washcloth up here on the skull and a towel around his neck, and I ran basically 13 and 77 and just felt the different tissues and 13 and 396 and just worked up here. Up here, for those of you that are listening, are the zygomatic arch and the facial muscles and under the chin on the left. And then, of course, finally remembered scarring in the vagus nerve from all the surgeries and tractions and all that. And took 50 minutes or so. And then we took the towel off his neck and his forehead. You know, when you do things that you didn't expect to do, that were, if you had thought about them, you wouldn't have done them because they were impossible anyway?
Yes.
Those things. So he took off the towel and the one on his head, and I looked at the trach. Scar had ridges of scar tissue, and took the towel off and went, it looks like skin. And his wife was there. And his wife said, look at this. Am I hallucinating? And she said, no, I've got the before pictures. There's lots of pictures of it. And we took pictures afterwards. There's skin here. It doesn't look like it's scarred. There's no stripes. There's no tight spots. It's just skin. And then you look at his face, and the places that didn't hurt, the left side felt weird. We'll fix that. So this all went away. But the other thing was, do that again. And he raised his right eyebrow. Now his left eyebrow works, but the muscle had been taken away, we thought, from the right side of his face. And he's sitting there, what? And both his eyebrows go up. Do that again. Do what again? Raise your right eyebrow. It takes a lot to surprise me.
I was just going to say, after all these years, to see you still get surprised, that's what us little people go through that.
Every day. It was just amazing.
So let's talk about frequencies that you use to get there.
The surprising thing is that if you think about the skin, we have a frequency for the skin. I didn't work on the skin. I worked on 77, the connective tissue. I was thinking of the muscles of the face all have broad, flat connective tissue attachments to the bone. I was thinking of that and the connective tissue in the muscle. It made me remember, after I saw the results, that the skin has a basement membrane that is 77. It's connective tissue. And that's what fixed the trach tube scar. Never occurred to me that just doing 13 and 77 would fix this. He had a trach in for 3 years. So,
But that would be something I think a lot of us would think about, no? Scarring in the connective tissue?
yeah, except that wasn't where I was headed. I was trying to get his face back, right?
Yeah.
And so just the wonder of, oh yeah, of course, it was 13 and 77, scarring in the connective tissue, the basement membrane to the skin.
Yeah.
And so next time, now that we have his right eyebrow moving, we'll go work on the muscles in the scalp that raise your right eyebrow and do more. I told him next time, if it's okay with him, I will bring gloves. His mouth is very small. The right side is bigger than the left, but they had to bring the skin over to form a mouth because he didn't have one. And so I said, I want to get the left side of your mouth the same size as the right side. So I'm going to put my finger in your mouth or let you do it. I just love my job.
So here's where I want to add some questions. So I am thinking of a patient that I work with. I think I wrote the case study on it and ended it at the advanced years ago. Car went down 200-foot embankment.
Yeah.
Like 22 fractures. I can't remember how many surgeries, infections, like it was a thing. And so that was where it became very prevalent to me to be careful how quickly we run 13 as we're dissolving scar tissue that has been holding somebody together for so long.
Yeah, good point.
So I'm wondering, I know it's not a joint like a shoulder, but there are so many plates and structures, joint-like structures around the skull. I'm wondering if running the 13 with that pain, was it moving up a fracture line or a joint line?
No, it was moving because a muscle that had not contracted or relaxed, this muscle had been strained by the scar tissue that held it down here.
Yeah.
Once it could move, it developed trigger points. No, in general, 13 or scarring takes away only scar tissue that is not useful. I've never had it take away too much. I've had it change motion so much that the brain doesn't have time to keep up.
Right.
The brain doesn't coordinate movement that hasn't moved in 13 years.
Right. Right.
So you take apart the scar tissue and then you hook up the brain, and then you take apart some more scar tissue and you hook up the brain. I've never had 13 take away more than it needed to.
Right.
His chin was metal. They moved the bone chips from the fractures up into the metal. And then as the bones filled in over the next 2 years, they'd take out pieces of the metal. And so all that's left of the metal is here. It's just, the pictures are amazing. So he has to sign a release. And then what I'm looking for anybody that's listening, what I need is someone to write papers for me. This patient is a case report. We have pictures before, during, after. I need somebody to write up my papers, and I don't have time. I finally confessed. There's no use beating myself up on Saturdays and Sundays because I'm not going to write a paper anyway. If I'm going to write anything, I'm going to write resonance recoveries. I'll just write chapter 1 because it pops into my head as I'm falling asleep. And if I get out of bed and go to the computer, I won't wake up and I won't go to bed again until 2 or 3 o'clock in the morning. And I can't do tomorrow on 4 hours sleep. So stay. And you can write up the book when you have a week off. So it's not going away, it's coming. There's that.
I like the internal dialogue. Stay.
Yes. The common sense. Finally, I had to be 70 before common sense started to win, especially when it came to sleep.
Right. So
I'm 55. I don't need more than 4 hours sleep. At 70, there's a part of my brain that says, you back in the box. It's like, you need sleep.
I need my 7-8 hours of sleep every night. Non-negotiable.
No, not negotiable.
It's funny that you organically talked about sleep because that is on my list. So we have a sleep protocol on the mode bank. I ask people every time I teach the sports class, I always say, close your eyes, and then I'll do my surveys because nobody wants to put their hand up if they're the only one. But if everybody closes their eyes, then we're more brave as far as like how we're going to say who here likes the sleep protocol. And it's like less than 25% pretty much across the board. Now, I never not put it on. I always still put it on for people. I still try it sometimes. But my surefire slam dunk way, if I need to go to sleep, is Concussion and Concussion in Vegas.
Yeah, no, the sleep protocol was developed before I discovered that we can treat the vagus and the midbrain. So there's this laptop that sits on my kitchen counter that has the mode bank in it. I have to go through 225 programs and change them all. And I've gotten 6 done.
Because the way you said that the core is being taught, it's really promoting us to write our own. Take some of the ideas from the mode bank, but create your own and create your own for the patients.
Well, I didn't spend enough time on the sympathetics. I didn't spend enough time quieting the cortex. I didn't realize the power of the hippocampus. What happens as you go to sleep is that your cortex quiets down. You stop thinking about the next thing to do. And that, if you think about the brain in segments, that leaves the midbrain driving the bus.
Yes.
The midbrain has all of the things that have bothered you, all of the things that you remember you need to do. So quieting the midbrain, turning on the vagus, and I spend some time quieting the adrenals, but not enough. And like when I have a lot of trouble sleeping, I actually did a salivary hormone test to find out if my cortisol was up, because I wake up at 9:30 at night. That's insane. And the thing that I can't fix with the sleep protocol is mold.
Right.
When I came back from Taiwan, I had 5 species of mold, all 5 of them. I've only ever had one. When I came back from Taiwan, I had 5 species of mold, and I had trouble sleeping. It took 4 times the amount of drugs that I usually take to sleep. I took that.
Wow.
And it's okay, I ran out early, but that's what made me test for mold. When somebody has trouble sleeping, when somebody has trouble with anxiety, depression, and digestion, sleep, anxiety, depression, digestion, test for mold. Real time gives you a urine mold test, costs $300. And then you say to the patient, and how much have you spent in copays for
Treating all those things separately, right?
Yeah, stuff that didn't work. There's
Right.
one thing that causes all of them. Let's make sure you don't have that. 100% of the time, that's what they have.
Right.
Actually, there was one who didn't have mold. That was a surprise. So then we had to look.
I have something to add. I love listening to podcasts, and there's one that I frequent like all the time. It's the Greatness Mindset podcast by Lewis Howe. He always has very interesting guests on. And a couple weeks ago, there was a neurosurgeon on, Dr. Ruhal Jandial. He is
What's the name of the podcast?
The Greatness Mindset by Lewis Howe.
Okay.
So Dr. Ruhal Jandial is a neuroscientist and brain surgeon, currently working at City of Hope.
Right.
He's doing a ton of brain cancer surgeries, and he wrote a book. He became very interested in dreaming, and to get his perspective on dreaming and sleep from somebody who is a neuroscientist, and very interesting. So he was talking about the pineal gland, and in our frequencies, we have frequencies for pineal gland. That's what we see a lot of with the sleep protocol. And it got me thinking why I don't love the sleep protocol or treating. It's not just a slam dunk with the pineal gland.
No.
What you had just mentioned, it's quieting down the parts of our busy brain. And so I don't know which episode it is. If you just Google the Greatness Mindset podcast and look for Ruhal Jandial, Jandial is Jandial. It's phenomenal interview with him. He talks about dreaming, different parts of our brain. And from his perspective, it made sense why we're on the right track with 40 and 89 and the concussion protocol. So to hear it from his very wise perspective, it's so nice when we can make those parallels. Like, yeah, that's why if it were that easy to just hit the pineal gland, then the sleep program would work. It would be a slam dunk. But the reason why concussion works and concussion in Vegas works, he has a very eloquent way of.
The medulla is the reticular activating system. It is the first messenger that tells everybody in the brain to wake up when there's threat.
Yeah.
And that means it's the medulla that tells the pineal gland what to do. Now, everybody talks about blue blocker glasses and all the things you're supposed to do to the pineal gland. The best thing to do for the pineal gland is to quiet down the medulla. It's brilliant.
Yeah, he talks about people who had complete resection of the pineal gland and they sleep just fine. He talks about melatonin. He really takes a unique spin on it. And like I said, because he is a brain surgeon, it makes you actually just sit up and listen, because He's got the interesting stories behind it. So yeah, I can't recommend that.
Well, and when we treat insulin and leptin resistance, it's amazing with that, the treating the pineal gland to increase melatonin, to increase insulin, to increase leptin sensitivity, that makes sense.
Yeah.
So it sounds like we should add 94 to insulin and leptin, 94. Everything is connected to everything. I just should paste that on the wall.
Absolutely. Let's get to a couple of these questions before I get to,
everybody's active this week.
yeah, there's a lot of stuff happening. All right, let's go to the top. You're looking at Michelle's question right off the bat.
Patient developed flu-like symptoms after a loud, bass-heavy arena concert, was first referred to an otolaryngologist who diagnosed sound sickness. In case anybody wonders, that's not a thing, and prescribed rest and very expensive custom earplugs. She is no longer symptomatic except for tinnitus. But now that we know about the effects of frequencies, we're wondering if any FSM practitioners have witnessed or learned of loud music causing flu-like symptoms. Okay, now think back in your mind to the vestibular section of the core. All of those 7 sides, when you're already exhausted and brain dead, it happens Saturday night or Sunday morning. And I give you a break beforehand. We have Kim's little dog that says, wake up, this is important. So your inner ear, that diagram, the 8th nerve comes in, there's the cochlea, bass sounds and high frequency sounds. And then there's 3 branches to the vestibular system. When you have bass vibration, loud sounds, you have not just the overstimulation of the auditory nerve that goes to the cochlea, you have overstimulation of the vestibular nerve. You can't hit one part of the 8th nerve by itself. That's the first thing. Second thing is, if you think about bass sound, there is a sound wave. It's like an airbag going off in your ear. You can feel it in your bones. You can feel it in your eardrum and your ear. So what it makes me think of is she had enough sound to damage or tear the round window or the oval window, because the amount of pressure that hits the eardrum, then you have the hammer, anvil, and stirrup, and the oval window, and the sound makes the eardrum move too much. It pushes on the bones, and at some point it tears the oval window, just a little crack in the edge. Now that opens the inner ear to outside air pressure, because you've got the eustachian tube right there. The feeling fatigue and flu-like symptoms, those of us that have Meniere's or any vestibular injury, those of you that have vestibular injuries, you know the flu-like symptoms that you feel when the air pressure drops. I can tell when it's going to rain because I want to take a nap and lay down. I take meclizine and that feeling goes away. There's that. I just wish Bob Grimm had published more. So there's that. It's open to outside air pressure. The air pressure drops and she just feels woozy and fatigued and achy all over, and her brain just wants to go to bed. The tinnitus is like phantom limb pain for your ears. The tinnitus is your brain humming to itself when the cochlea is not getting input from the hair cells. So the hair cells do their thing and they convey sound to the brain. When the brain isn't getting information from the hair cells, what's it do? It's phantom limb pain for the ears. So the tinnitus is damage to the cochlea, hair cells, and ultimately both of them are the result of damage to the eighth nerve, both the vestibular nerve, probably the oval window, and the cochlea. No longer symptomatic, except for tinnitus. What tinnitus tells you is that the cochlear portion of the nerve didn't recover, which means the vestibular section doesn't recover either, which means you should do a vestibular exam on her, send her to an FCOVD when she flunks the vestibular exam. And it's why I don't go to rock concerts. I went to Peter, Paul, and Mary and John Denver 70s, and that's it. And I didn't Matthews. I went to his band once in an arena, but I wore earplugs. These people are crazy. They're going to be deaf by the time they're 45. Sorry, Michelle, I just go off when it comes to the inner ear. Hi, Deb. Email to contact Kim.
Oh, just Kim at fsmsports365.com.
Sports 365 days a year. There you go.
We could say FSM works with sport 365 days. So yes, Kim, fsmsports365.com. Okay, questions are around here. Hang on.
Proactively treating chemo side effects of lowered RBCs. So what makes red blood cells? Your liver, I think, and your bone marrow. You treat chemotherapy starting the day they start chemo, and you help their liver and their bone marrow process it. So you're on 57, 900, 920, and 225 on liver, blood, 103, and maybe the bone marrow. I haven't had much success treating the bone marrow because it does so many things I don't understand, and I'm not even sure it makes red blood cells, but I think it does. And proactive, you can treat chemo side effects of cisplatin and prevent the neuropathy, because we did that for one of our IFM friends. So way to go. Christmas tree above, bumblebee below. Actually, I did it backwards because it was alternating. No, I had the red and green on his neck and the black and yellow on his head. And if it's alternating, it actually doesn't matter. So I don't do more of that. I'll let you take this one from Mary.
Mary is experiencing more tinnitus, depending on what part of the country you live in these days. She pulled the protocol from the Facebook site, have yet to create in the custom care. Do you think sleep protocol would be better than the tinnitus protocol?
What do you think? I have a prejudice about tinnitus because the person I respect the most in the world is an audiologist, PhD audiologist from Good Sam. And I had tinnitus for 3 years after I got Meniere's, by the way. And she said, tinnitus is phantom limb pain for your ears. That's it. My tinnitus is gone during the daytime. And at night, I take my hearing aids off, the tinnitus comes back, but then I fall asleep. And after all these years, I've gotten used to it. The patient is going to whine about wearing hearing aids, and then you tell them, okay, I use the supplements that are supposed to be good for tinnitus conscientiously for a year, didn't do anything. I treated my SCM, that didn't do anything. I resisted doing some of the weirder stuff that people have you do for tinnitus. And then I called Sue, and Sue said, it's phantom limb pain for your ears. And I went, duh. So I tried 40 and 89, that didn't work because it's the auditory centers, and which is a different frequency. And I just got hearing aids. And for me, it's a business expense. They're not from Costco. And they are little computers that are stunning. It's that big. And they had an upgrade. So I bought a whole new pair. And the noise filtering is extraordinary. So I can go into a crowd and it filters the noise automatically, the background noise. And if I have to, and I'm in a restaurant, I push a button and it turns off the microphone that picks up the rest of the room and just turns on the microphone that's listening to you. They're just extraordinary. They're called ReSound, R-E capital S-O-U-N-D. And if you want to get them to Costco, go ahead, because they don't carry ReSound, they carry other brands. And my audiologist is in his 40s and he's a PhD trained at Walter Reed.
Wow.
So look for an audiologist that knows his stuff, that you like, because this is a relationship. When you first get hearing aids, your brain has turned up the gain. So people that say my hearing aids are too loud, the brain turns up the gain. So when they first dispense them, it's 50% compensation for your hearing loss. Then at about 3 months, you turn them up and you turn them up and you turn them up on your phone. And then you go and say, oh, my hearing's worse. And he said, no, now your brain is adjusted. So then he compensates 100%. The more expensive ones do a better job at filtering. And the other thing is they have demonstrated that people that have hearing loss, even if it's only one-sided, but if they have hearing loss in both ears, their brain stops processing auditory information and all information less effectively. So you have a higher incidence of dementia in patients with hearing loss. So suck up your ego, put it in a box under the seat in the car, and then drive to the audiologist, find someone you like, and get your hearing aids. And it starts at 50 and 60. I was 60 something, and my daughter said, Mom, you say, huh, too much. What'd you say? And the TV's way too loud. So there we go. Alf. Fluoride and calcium build up in the pineal gland before 49. Okay. That's cool. I'll go with that.
Giselle asks, if the temporal cortex is constantly alert, keeping the brain alert, would concussion protocol help sleep?
I don't know that much about the temporal cortex because I don't have a frequency for it that I totally trust. So I don't know. Oh, interesting. I don't know.
Debbie Benden is going to send in some case studies. That's great. I'm going to get to my question that was emailed to me because I have a couple of things that jump out at me. And so I'm going to...
Can I do Alf's first?
Oh yeah, I thought we were done. Go ahead.
In regard to the transection of the pineal, the majority of the melatonin in the body is produced in the gut. So we should do 40 and 22, 81 and 22. If it's produced in the gut, 81 and 22. Thank you, Alf.
Very interesting.
Okay, question.
Okay, let me pull it up here. So there's a couple things. So like I said, this is coming from okay. This person is a PT treating a 47-year-old male with bilateral lateral epicondylitis.
Wait, what?
Okay, so very good. That should be the first question mark, right? So the first statement is 47-year-old male with bilateral epicondylitis. Okay, so right as you put your detective cap on, you are like, something should be jumping out at you right away. The patient is a cabinet or closet maker who uses his arms constantly all day long. The person has had 5 FSM treatments using the custom care. She applied the acute and chronic epicondylitis programs from the Mode Bank, only had minimal improvement. So she said about 20% improvement. And that improvement doesn't last very long. She puts the electrodes at the shoulder and distal to the elbow. He also has some shoulder discomfort as well around the rotator cuff insertion. She's using alternating, wondering if she should change it to positive. Then she does gentle cross fiber friction towards the end of the program. He complains a lot of pain right on the bone. So they also tried to add bone frequencies such as 40 and 59 and 39 on the B channels. And when she added those frequencies, it increased the pain and the discomfort.
Yeah.
She should add that he's had this for 6 months and he doesn't like to go to the doctor to deal with it. So I know. So I thought for a reason this would be a good one to share because we see a lot of epicondylitis, and remind me to tell a story about epicondylitis as well. But the first and most important thing is I hope we're on the same track, or if I'm right, you're going to target. So take it away.
In the first place, it's not epicondylitis. That's why the treatment doesn't work.
Because?
It's nerve pain.
And why do we know that?
Because epicondylitis doesn't work. And because lateral epicondylitis, if you look at what he does for a living, he uses his hands, but he has his neck bent, right? And is he using his hands overhead?
Oh, as a cabinet maker, I would imagine, right? You're installing a lot here, but using both.
Right.
Hands. But the big word too is bilateral.
Yeah. You do his reflexes, you do his sensation. Now, I hate to be a chiropractor about this, but there isn't anybody in our group, even a massage therapist is not allowed to make diagnosis, but they're allowed to do a physical exam. Quick, pinwheel, $19, reflex hammer, $6, whack. Hyperactive patellar reflexes, reduced triceps or brachioradialis reflex. Okay. And icky C5 and C6. And then, so the reason it doesn't work is you have to go from the neck to the wrist, or the neck to his elbow, and treat 40 and 396 for an hour. And the other thing is that the epicondylitis, the muscle wouldn't be tight enough to tear the tendons, pull them away from the periosteum, unless the nerve was driving them crazy, making them too tight.
So Jillian is actually replying live right now because that was her question. So I just want to see if she added something. It's bilateral, but right has been longer than right. Has been longer, maybe than left. Has chronic cervical herniated discs diagnosed by MRI and X-ray.
Oh yeah. So it's a broad-based right paracentral cervical disc. So the way to treat it is his arms aren't his arms. So if I don't teach anybody anything else, it's please ignore the presenting diagnosis. They do not have supraspinatus, tendonitis, and bursitis.
Right.
They have a subscapularis.
Yeah.
He does not have bilateral epicondylitis. He's got C7, C6 neuropathy.
Yeah.
Period. And then the epicondylitis is just collateral damage and it's a red herring. Yeah. And it's a right paracentral. So central means it is mostly in the middle. It's broad-based, but it squishes out more to the right than the left. And that is because he's right-handed, I would guess. And the one thing to check on him is the tone in his adductors and his quadriceps. Because the next thing that's going to happen is knee pain. Because if it's broad-based, it will bulge out towards the center when it runs out of room on the side. The next place it goes when he does this and that is it's going to go in the middle and it's going to tighten his leg muscles. And you think, oh, I just have knee pain. Yep. Oh, no way. Yes, he's right-handed, and yes, tender along the adductors. Thought that was from low back issues.
But this is why I wanted to bring it to the podcast, because it is so much what we see. And if you just look on the surface, you would think cabinet maker for sure. There's probably some forearm tightness from using their arms. But when you look at it from a different perspective, the way that we are treating it, it changes everything. And yeah, I would have never put quadriceps adductors with a neck issue ever before meeting you.
You're welcome. And I'm sorry.
But do you know what I mean? So that's why I thought, so there's so many brilliant PTs, chiropractors practicing along these lines. And this is just another tool. And when you treat your hypothesis, and you're always so good at it, create a hypothesis. Okay, we have bilateral epicondylitis, treat it, doesn't work. Okay, it's not because FSM doesn't work. Your hypothesis was wrong.
And you treat it one time, you don't treat it four. Or if you're really chicken like I am, you treat them both at the same time.
Right.
It doesn't hurt to treat 40 and 396 and treat the nerves, and then play with the elbow because he thinks his elbow hurts.
And she just mentioned, would you ever have to do myofascial to the forearm musculature, or no, because it's never the muscle? So two ways of looking at it. I would absolutely, sure, you can do some myofascial work because it will feel good. I have no doubt about it that those forearms need some attention, but it's not going to treat the pain coming from the neck, but it makes the patient feel good. And there's no harm in treating those muscles because they do think it's the elbow.
And the other thing is that you run one that's 40 and 396, and you run one that's 124 and 77, because it's a flat tendinous attachment here. And then maybe 40 and 783. And you can treat, I forgot, PTs use pad placement. So you use the 4-inch ovals, and you put red and green at the neck, but you have to wrap so it catches the exiting nerve root. And then you put one black one down on one arm and one yellow one down on his other arm, red on the right, red right, and black on the left, green, yellow. And you got it covered, but you have to use 4-inch because when you're treating nerves, you have to cover the lamina. You have to cover the foramen and treat the nerve as it exits.
Use towels in that case, and then you can put both hands on.
Yeah.
Yes, she has wraps. So
yeah, wraps are perfect because you use one big one for the neck and one little one for each arm. I treated a cerebral palsy patient yesterday. It was so much fun.
Talk about it.
Yeah, it was just 81 and 10. Yeah. So I was treating her mom for fibromyalgia. And I love you too. Do good things, Jill. This is so exciting. The mom was a fibromyalgia patient, and mom's pretty easy. So she said her fibromyalgia, the tender points, her pain level was a 5. They started out as a 7. And then it went down to a 5, and it's been 5 for, I don't know, 10 years. And so you used to be a 40 and 10, and then the disc healed, and you're now centralized. Excuse me, she's a nurse, so I can speak medicalese to her. And I said, never mind, it's just 40 and 89. So I ran 40 and 89 neck to feet. And then I did disc, vagus. And then yesterday she said, oh, I have bilateral plantar fasciitis. That's a good face. Good job. You have chocolate and a hug. And so I said, you see these leg muscles? Your hamstrings should not be then tight. So I used my algometer and I pressed on the medial side of her knee, and it was tender to 1 pound per square inch pressure on both sides. And her arms, 1 pound, both sides. And she said, on my thumbs really hurt. So I did 81 and 10, wrap around her neck, and a wrap around each foot, red and yellow, black and green, blah, blah, blah. But then with the arms, towel around her neck, and I put her hands up here, and I wrapped both her thumbs in a washcloth so she could have her hands comfortable. And we just sat there and talked and hung out. And I didn't do anything. You could find some tender periosteum. So I ran 40 and 783 for a second, but mostly it was just 40 and 396. And she said, it's gone. Yeah. How? My arms don't hurt. Yeah. Why don't my arms hurt? And I said, well, because it's a C6 nerve root. If it's this is a 6. If it's this, it's a C6 nerve root. And it goes clear up to here. And she said, test the tender point in my arm. It went to 7 pounds from 1 pound. And her knees, after we did 81 and 10, went from 1 pound to 5 pounds. She's now ecstatic. And the kid is a heroin baby. She's, what do you call, it's not a rescue like a cat, but they're foster parents. And they got her when she was an infant. And when you look at the kind of cerebral palsy she is, it's the kind of cerebral palsy where they have developmental delay. She can see really well out of one eye. She plays with her iPad like this. And the CP affects her arms. But you can tell that it's not localized in one area or 2 areas of the brain, that it's more than one. And I said, I'm going to bet that she was 30 days early. So I'm going to bet that she had seizures, that she was delivered and they didn't know mom was on heroin. So they found out she was on heroin and did the blood test after the kid was about 4 hours old and had seizures. But when I looked at her, their left leg was more adducted than her right and more spastic, generally lower left. And I can't remember if it was right or left. Anyway, so I said, that's the pons. And they said, what do you mean the pons? It's the only patient I ever saw that was completely rigid and spastic. And that 81 and 10 didn't work on was somebody who had a pons stroke. And the pons in an infant, if you look in an adult brain, it's about the size of a kumquat. It's about this big. It's at the top of the medulla. In an infant, it's going to be the size of a kidney bean. It doesn't take much of a seizure or a head banging around to bash it up a bit. So they're going to come, the dad is going to come in, bring the daughter, and we are going to treat just her on the table. He's going to do the manipulation, and I'll be able to see if the pons has anything to do with it, and we'll just add the kid to their custom care because mom's going to buy a custom care. And treating the mom has been an exercise. My partner rolled her eyes and gave up on her, said, I'm sending her to you. She wants to see the guru, and it works for me. She comes in with a foam thing she has to lay on because her skin is so tender. I thought, you're centralized. And she said, what? You're centralized. You don't, your pain level's a 5. You don't have fibro. My pain level's a 4. I don't have fibro. But your brain thinks your pain is a 7.
Right.
So it's 40 and 89 and 81 and 10.
40 and 89 has really just changed everything. 40 and 89 and treating the vagus. So again, I'm going to an island all by myself and I can only bring a couple of frequencies. I'm bringing 40 and 89 first. And then I'm also bringing increased vagal tone because you'd made mention of something, I think it was last podcast or the podcast before, that really has just stuck in my brain. And we talk about inflammation a lot, whether it's with chronic pain or chronic illness or recovery for athletes. And people are afraid to use 40, but do you even need to? And I guess that is what you had brought to clarity the last podcast was, If the vagus is doing its job, it's going to control the inflammation.
Generalized inflammation for sure. I still think you need 40 and 396 to treat the nerve.
For sure.
I would not go to a desert island if I couldn't take 40 and 396
No.
and torn and broken and everything.
Absolutely. And let's face it, when we have somebody that comes in with an injury, that's why there's multiple machines, because you're running 4396 because you always have to get them out of pain first. And then you need to run 4089 because you have to.
This kid that had this horrible injury to his face, yesterday I ran 40 and 89 on him. It didn't change his discomfort. He's not in a lot of pain, but the whole physiology of his face, his whole body tone. Can you imagine the trauma? Something like this happens when you're 14 and you're now 40. Where's that stored? And I ran 40 and 89 on him, and it's, oh, baby, I will catch you on Thursday. So we'll give him the full meal deal on Thursday. He'll have multiple machines. Because I'm really careful with patients and do one thing at a time in the beginning.
Yeah.
If they're at all fragile. And I didn't know him, and his injuries are really severe. And on Thursday, we will do concussion and vagus, because that includes 40 and 89, and turn on the vagus. And I might tweak it a bit to add more time on 40 and 89 and more time on 81 and 109, and then play with the rest of it. I think you're right.
No, that's you. You are the one that mentioned that. Again, especially with recovery, right? So when you have an athlete or somebody who's like patients who buy custom cares, all the athletes want to, they want to use it for recovery. That's where our claim to fame really skyrocketed, especially in professional sports. Part of it is getting them to sleep at night. So I said, it's not this crazy magic box, but if I can get you to sleep better, that we're trusting in your body's ability to repair at night. But if you are up all night, inundated, replaying the game, what happened, what went well, what went terrible, rumination, like all of that. So again, it's not magic. It's just getting your body to do what it's meant to do.
There's a little bit of science involved in the fact that 85% of growth hormone in an adult happens in deep sleep.
Absolutely.
So you get a maximum of 10%, 12% deep sleep. So it's something under an hour of deep sleep out of 8. And 85% of your growth hormone is made during that period of time.
And yeah, everybody seems to have the Aura ring, and that helps us. And you'll see your little graph, like we don't spend 8 hours in that deep sleep. And a lot of data is showing that it happens between 10 p.m. and 2 a.m., regardless of what time you're going to sleep at. So they used to say deep sleep was peaking, I think, after 3 hours after you fell asleep. And now they're changing now 10 p.m. to 2 a.m. So that's why we want to get in bed early. That's why you can't stay up all night writing books.
Right.
So.
And I'm a pitta in Ayurvedic medicine. So the high time of my day are 10 a.m. in the morning till 2 in the afternoon, 10 p.m. at night till 2 a.m. in the morning. Well, there you go. So, right. But it's absolute. You're absolutely correct. It's 10 to 2, and it means you eat your biggest meal at lunch. You either have a little snack for dinner or almost nothing for dinner, light food at dinner, no alcohol. If you're going to have a glass of wine, have it at lunch. And then there's this stuff called REM maintenance. It's a lot of glycine. And my OBGYN, who desperately needs to sleep more, told me, I said, how do I get more REM sleep? And she said, oh, take this stuff. Okay. My ring really likes it.
Well, that's good. If your brain likes it, then that means the
Yeah.
right. Yeah. And again, just going back to the sleep, we started with sleep and I want to finish with sleep. We talk about getting a patient out of pain, and that should always be like the first part of your, I know the hour went by like,
Wait,
and we even started early too.
okay, all right, good.
This is the vortex. That should be the name of the podcast, the vortex of lost time.
It is, it's just like, how did, it's like a black hole.
No, but like I said, to simplify, if you can get somebody out of pain first and then get them to sleep better at night because they're out of pain, that is huge. So as complicated and as overwhelming as some of these cases can be, I just strongly encourage all the practitioners that are listening to just remember those two very basic things and how important that is to have somebody sleep better and just
quiet down the midbrain. Last week is, put the midbrain in a blankie.
yes,
Have it go night.
yes,
Give it a nap.
yes,
Tell the amygdala to take a nap. And I think it's tell the hippocampus to take a nap. Because
yes.
it's not emotion. They usually suppress emotion.
Yeah.
Because they're tough.
Yeah.
Wrap the hippocampus in a nice little cashmere cushy and have it take a nap.
Somebody who's good at art, can someone please draw this happy little hippocampus in a blanket, please? Because I'd like to have that slide.
Wouldn't that be great?
If I can commission somebody to do that for me, I'd appreciate it.
The first thing we actually need is somebody who wants to write papers.
Yes. Okay.
I will pay you.
Yes.
I'll give you everything you need. I just don't have time to write them. And that's just the way it is. And once you start writing them for me, I will put your name out there and you could make a living writing papers for other people, because every time somebody publishes a paper, I will give them and you $2,000.
That's a good call to action. There's got to be some students out there that want to do stuff like this.
That's good discretionary cash. And I have to remind you, I'm not going to be here next week or the week after.
Oh, so I was going to say, I won't be here on the 22nd, but I can put something together, I'm sure, next week. We'll let everybody know.
You could actually be brave, and the team that's listening will help you. Because when I was stuck here by myself, I just said, you guys better ask questions, because otherwise I don't know what to talk about. And we answered questions for 60 minutes.
Okay.
So be brave. You're ready. You can talk, and they'll ask questions and you'll answer them. And my guess is you'll be right 99% of the time.
Ooh, that's.
And then at some point, I did a podcast early today for one of our practitioners, and we started talking about the process of recovery.
Mm.
When you get them out of pain, then what?
Yeah.
How do you give someone a new perspective, a new view? How do you help them? Your job isn't finished when they're out of pain. If they've been in pain for more than 2 years, your job isn't finished. They need support. And this is why it's twice a week for 4 to 6 weeks. They're done at week 3, but you have to be with them to help them recover. I want that to be a topic. I'll put it on your list because you're better at lists than I am.
Yes.
So
I love that. That is what started the sports course, in my opinion, is what do you do when they're symmetrical, when they're out of pain? Like you said, it's just starting.
Yeah. Oh, and the emotional part of it and the psychological part of it, as well as the physical part. Part's easy if you're a PT or an OT or a sports coach or even a chiropractor, but the emotional, spiritual, psychological part, that's Resonance Recoveries. That's the name of the second book. I got it. And I've got the first chapter in my head. If I can ever get, I have a week's vacation planned this summer before we go to Hawaii. And I'm going to the beach with the dog.
Good.
And I think I'll take my laptop with me.
There you go. Just do it.
that thing. That could be fun. We can talk about input and all those good things.
Yes.
I don't want it to be 4:00.
It's 4:04 now.
Oh, okay, good. Then we're on making time if we're 4 minutes late.
Yeah, and it was weird because we started 5 minutes early, which is like Pittis time.
Okay.
There it is. There you go.
Yay.
All right, so I won't see you next week, but I'll see everybody else.
Yeah. Next week we are doing a core seminar in Troutdale.
Right.
It's supposed to finish at 5, but it finishes at 6 or whenever. And I can't take time out to do the podcast, but if you haven't signed up for the core yet, come on and join us. It's going to be fun.
Yes.
I love our new space. I have to take pictures and send them to you.
Yes, yes, yes. And we have to still talk about putting a sports course in. I think we've decided October, but I'm just not sure when to have it with
We're
you.
only going to do one.
You can do
Are you feeling all right?
that.
We're going to do one? Really? Okay. All right.
I'll have another one at the advanced.
Say again.
She'll have another one at the advanced.
You'll have another one at the advanced. And
Yes.
you actually do have a life and a family and
Things got very busy this year, but yes, we'll do one, I think, in the fall, and then we'll just do it every season, I think, moving forward, because then we have Kona in the summer 2025. We're getting the calendar cooking.
we're getting it cooking. And now that we have, the name of this facility is the Frequency Specific Microcurrent Conference Center.
I love it.
It is the Troutdale Conference Center. And it's amazing. It's got chairs, and Kevin found rolly chairs with wheels on them and no arms.
Oh,
So you can scoot the chair around like a doctor's stool.
Yeah.
Permanent tables. We bring the metal carts from the clinic in. So you're working like you would work at home. You have a metal cart with the machine next to it. And we have extra machines for when we go off script. And there's a lovely view of Troutdale. It's so much fun.
yay. It's a beautiful space. Can't wait. Have fun. And we will.
I'll miss you next week. Have
Yeah.
fun though.
Thanks.
It'll be fun.
Yes.
Right. It'll be fun.
Okay.
Bye.
Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts, or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.